Good afternoon and welcome to the 2022 Dean's Colloquium, the focus of which will be human trafficking is a public health issue. I'm Dr. Jonathan Miller, the Dean of the College of Arts and Sciences here at UNE, and it is my honor to host today's event. This year's Colloquium is presented by UNE's Center of Excellence in Collaborative Education in partnership with HEAL Trafficking and made possible with the generous support of the U.S. Attorney's Office, District of Maine, UNE's Office of the Provost, as well as the College of Arts and Sciences, the College of Osteopathic Medicine, the College of Westbrook Health Professions, College of Dental Medicine, School of Pharmacy, and the Online College of Professional Studies. Human trafficking is an issue that intersects all aspects of life and thus has relevance and resonance with all of our academic programs at UNE. In the College of Arts and Sciences, for example, Dr. Alicia Peters is our resident expert. In fact, Dr. Peters, an associate professor in the School of Social and Behavioral Sciences, is on sabbatical leave this year, working on a manuscript titled Human Trafficking, Vulnerability, and Prevention, in which she explores how the response to human trafficking has changed over the last 10 years, with a focus on Maine and northern New England. Her work provides critical analysis of various factors that contribute to vulnerability and identifies how trafficking is conceived at the local level. I believe Dr. Peters is joining us today. The full extent of human trafficking, both labor and sex trafficking, is difficult to quantify because many cases are never reported. This is, of course, true in Maine as it is everywhere. Still, one study in 2015 found there to be as many as 400 cases of sex trafficking in our state. And in 2021, Preble Street Anti-Trafficking Services received 310 referrals and served 84 human trafficking victims, 73 of whom were from York, Androscoggin, and Cumberland counties. Even more shocking, over the last 3 years, the Cumberland County's Children's Advocacy Center has served 36 confirmed victims of trafficking who were minors. Just as startling is the disproportionate number of cases being prosecuted. As of 2019, the U.S. Attorney's Office had only 10 sex trafficking prosecutions in Maine, with an additional 6 prosecutions for other charges involving identified victims. While Maine is far from the epicenter of trafficking in the U.S., the Federal Human Trafficking Report ranks Maine last in the nation for the number of new criminal cases and 39th for the number of active cases. It is nonetheless an issue by any measure that demands our ongoing attention. With that in mind, I'd like to clarify 10 myths for you about human trafficking to further contextualize today's discussion. Myth number 1, human trafficking is usually a violent crime. In fact, most cases are based on psychological manipulation, such as trickery, fraud, or threat. Myth number 2, all human trafficking involves commercial sex. In fact, evidence suggests that there are more labor cases than there are sex cases. Number 3, only undocumented foreign nationals get trafficked in the U.S. In fact, there are thousands of cases involving foreign nationals who are legally living and or working here. Myth number 4, human trafficking only happens in illegal industries. In fact, cases have been reported in restaurants, cleaning services, construction, factories, and more. Number 5, only women and girls can be victims of sex trafficking. In fact, as many as half are male. Even more, male victims are far less likely to be identified, and LGBTQ boys and young men are particularly vulnerable. Myth number 6, human trafficking involves transporting a person across state or national borders. In fact, the crime of human trafficking does not require any movement at all. It can take place in one's hometown or even in one's home. Number 7, all commercial sex is human trafficking. While this is true for minors, commercial sex involving adults is human trafficking when the person is doing so against their will or because of force, fraud, or coercion. Myth number 8, if the person initially consented to being in that situation, it cannot be human trafficking. In fact, initial consent to commercial sex or labor prior to acts of fraud, force, or coercion is not relevant to the crime. Number 9, people being trafficked are physically unable to leave and are being held against their will. And while this may sometimes be the case, people usually stay for reasons that are far more complicated, like not having access to transportation. And finally, myth number 10, traffickers target strangers. In fact, survivors have been trafficked by family members and even romantic partners. So as you can see, human trafficking is indeed a complicated matter, and there is much to learn. Like you, I look forward to today's colloquium addressing this critical issue from a public health perspective. Thank you.
Well, welcome everybody. I'm not really used to addressing audience of people, and I'm not used to being at a podium, so I'm on my toes. And I have a memory of speaking at a podium. I'm Shelley Cohen-Conrad, the director of the Center for Excellence in Collaborative Education. And I want to thank our folks, Chris Hall and Michelle Cody and Lee Cody, for the support they're giving us today for this highly complex event. Not only is this event complicated in terms of logistics, but it's very complicated in terms of content. And although what we're presenting today, what our speakers are presenting today is critical to you as future health professionals and anybody who's going to be in programs and disciplines that serve people, we're also very well aware that this can be disturbing and the content can be very difficult. First of all, we want you to take care of yourselves. If the content is difficult and you need to step away, that's fine. If you just want to step away in your brain for a little bit, that's fine too. We also want to tell you that the counseling services here are available to you, and I'm hoping we can put those numbers in the chat. It's available 24 hours a day, should you need more support. There will be 2 breakout sessions today. And as you begin thinking about that and listening to our amazing speakers, we want you to pay attention to red flags that are being named and being spoken about and are raising awareness for you, because that's what you're going to be talking about in your breakout session. So notice these things, pay attention, jot them down. Finally, before I introduce our speakers, we are not just going to generally take questions and answers. We are going, if you notice in the rooms where people are actually sitting, there are no cards. If you want to jot questions down, I will be bringing the questions forward. Those of you who are exclusively on Zoom, put them in the chat, and I will be taking note of those, as will Michelle, and we will bring them forward at the very end. So it is my honor and privilege to present our speakers today. Our first speaker is going to be Fainess Lipenga, a labor trafficking survivor and training advisor at the Human Trafficking Legal Center. Our second speaker, Dr. Hanni Stoklosa, is a physician and has a master's in public health, and she is the founding CEO of HEAL Trafficking. So, Fainess, you're on. Thank you so much.
Good afternoon, everyone. I'm so honored to be here. Thank you for a beautiful introduction. I was a victim of labor trafficking to the United States. I was brought by somebody I trusted and knew. I had worked with my employer back home for 2 years, and she was called to work in the United States of America, Malawi Embassy, as a diplomat. Next slide, please. And everything was fine. There was no red flag. Next slide, please. Next slide, please. Oh, I'll just continue talking. This slide is not changing, so. I was granted a free visa. Some of you who doesn't know what a free visa is the visa that is granted to domestic workers for diplomat. I signed the contract that was written in English. I didn't understand at the time. But I was young, and with the promise my trafficker made to me that she will help me to find a better job and a better opportunity here in America, so I can go to school and help my poor family. I dropped out of school because of financial hardship as a young child, just born because of financial hardship with my siblings. So, hey, next slide, please. We landed in this country, in this neighborhood. That was me here to the right. I was in my 20s. When you were 20s, what were you doing when you were in 20s? You just want to take over the world, right? So I was ready. I was so excited for the opportunity. We landed in this beautiful neighborhood, as you can see, very clean. But I was trapped in this house. My trafficker changed to the tiger. She wasn't the same person I had known in Malawi. I was working long hours, more than 16 hours a day. I have to clean and iron every single clothes, including underwear. It's not only that, my trafficker was threatening that when I ran away, she reported me to authorities because she has immunity. She said, she used a lot of words, immunity a lot. She said she cannot get in trouble. Up to this day, the word immunity sing a song in my head. I was forced to sleep in the basement because she said I cannot use the lotion or soap, not even toothpaste or toothbrush, because I was sure I would make the family contaminated. I was paid $0 to less than 40 cents an hour. Hello, in America, who does that? Not only that, I developed a lot of medical conditions that never been treated when I was there. As well, I was forced to eat in the kitchen by myself, leftover, sometimes not at all. My trafficker one day, there was next slide, please. There was people coming to the house all the time, but those people never say anything, never ask me anything. As well, there was like cars passing up and down in that beautiful neighborhood. Nobody ever stopped to look at me to see what is going on. So I was invisible the whole time. Additionally, my trafficker was recording, monitoring me when I was working for no reason. I suffered mentally, sexually, emotionally, and physically when I was working there. There was no communication between myself and my family because my trafficker was listening and disconnected the phone. Next slide, please. Now, next slide, please. Additionally, doing chores in the house, my trafficker's partner owned the industrial business carpet cleaning. So additionally, I was transported in the middle of night. Cleaning the carpet in industrial business, like nobody still look at me. And I have to go back, continue doing the chores in the house. Next slide, please. I talk about red flags. There was a time, like me shoveling the snow in the drive with 20 inches of snow. And the police officer was just living next to us, not even that police officer intervened. Next slide, please. One day my trafficker came home late. The garage always make noise when it click, and that day it didn't click. And I saw my passport and my contact, and I ran away for my life because I thought I would die. When I died, they'll dump my body in the dumpster, but I wanted to die in the street, so maybe people would find me, my body, and like maybe my family will have a closure. I ran for my life. Next slide, please. I took my trafficker, a treatment to court. I win my case, but up to this day, since 2016, after 6 years, I have not received any penny. I'm still deserve compensation. Next slide, please. Now that I have shared my personal story of labor trafficking with you, I want to be clear that human trafficking can happen to anyone, regardless of gender and nationality. And it can happen to boys and girls too, and boys and men too. This is a big issue and a topic that needs to be discussed. It happens even in your backyard. human trafficking is a disease, and we need to find a cure, and time is now. I'm here today to speak with you because medical personnel can play a big role in identifying human trafficking. You will come in contact with people like me, people with lived experience in daily basis. But because times people are not familiar with trafficking, they don't know what to recognize the red flags. Now, I'm going to share with you some of those red flags and missed opportunities. Hospitals are a common place for trafficking victims and survivors to go to. Medical personnel should be paying attention to the physical appearance, body languages, and the way a patient is communicating to help identify if they are possible victims of human trafficking. In my case, I was crying, I was confused, I was aggressive. I showed a lot of signs, but like the medical personnel failed me. The system failed me terribly because I wasn't identified as a victim. Not only that, the medical personnel allow my trafficker show up in the room, and my trafficker wasn't announced, just show up in the room. Remember, my trafficker was saying me when I ran away, she put me to authority, so she showed up in the room from nowhere. I mean, like now I can look back, I think about HIPAA. Where was HIPAA? Where was my rights? Not only they did not protected me, they weren't able to connect me to services that I needed, social services and the mental care. Another example, look at the clothes a patient is wearing. Are there any appreciate for time of the year in your area? Does the patient appear to be homeless? When noticing these details, medical personnel should dig deeper and ask more questions rather than moving on with the assumption that the patient is homeless. What is the patient body language telling you? Are they avoiding eye contact? Are they shaking or struggling to answer when you begin to ask routine questions? Are they beginning to cry? I did all of that. But like again, I was failed. Does the patient have any untreated injuries? Does the patient have signs of sexual abuse? Does signs of abuse physical consist with torture such as broken bones and bruises? Do they have severe denture decay? Years ago, I visited Howard University Hospital room many times with tooth pain. Removal with cavity, a lot of cavities all over my mouth without any ID, no any credit card. I was refused care one time. In total, I visited to the emergency room 6 times or more. No one was able to put together the red flags. This was 6 missed opportunities to stop the abuse. I'm gonna give you example of 2 scenarios. When I visited to Howard University one time, the doctor was, I guess, concerned. So they end up brought up like another doctor, and that doctor turned out was from my country, was speaking my language. And I was able to share with that doctor after he addressed that doctors are worried because you have a lot of big cavities and you are losing teeth so young. Why do you have like a poor mouth like this? So I was able to to share with him that I was being abused. I did not say that I was a victim of human trafficking because I didn't know that I was a victim, but it was good enough for me to communicate because he was speaking my language. But it was his response. He told me that I have to go back to my trafficker because I should just be grateful because I'm in America, because back home, young girls like me, a lot of young girls, they are dying to come to America for the opportunity that I have. The same thing my trafficker take advantage of. So I went back to my trafficker. And the same scenario, similar scenario. I visited, I'm in a clinic with my trafficker 2 times. They speak on my behalf. The 3rd time they give me direction to went there. And when I get to that doctor's office, he looked at me and he was like, "Fainess, you're gonna die. You look like a skeleton." And I sat down and he asked me questions. So he acknowledged the red flag you were talking about. And I was able to share with him because he started with conversation, asking me, having concern. I was able to share with him what was going on. And this doctor told me that he's going to help me to escape. But what he did was he turned his back and he reported to my trafficker, and that put me in danger. Another red flag is, look, if the patient abandoned at the emergency room, and that is another scenario. The first time my trafficker took me to the emergency room near the hospital when my mouth was swollen, she drove me in the street and just pointed emergency room. I never went anywhere. That was my first time. I'm going to have to find myself my way to emergency room. Does the patient accompanied by individual who who refuses to leave them alone with the medical team? That's another flag. Inability to produce identification document, not knowing their home address or having a large amount of unpaid bills. Many victims have their personal forms identification stolen from them by traffickers. They are not told where they are being held and have no way to pay their medical bill. And that was also my case because I made a lot of trips in Howard University. I ended up like owing the money of $5,500. Then I couldn't even go there because my trafficker was refusing to help me to pay the bill. Next slide, please. Communication with victims. Communicating with victims when English is not their first language, don't speak, please, don't speak jargon ways. Speak simple, straight questions so the person who are in front of you, especially a magnitude population like me, can understand you. In my experience, in many other victims of labor trafficking, and are brought to the United States from other countries with little to no English language skill. It is so important that medical personnel invest their time and their funds in the trauma-informed communication with their patients. It's the medical personnel job to provide skilled medical interpreter to communicate with the patient in their own native language. I'm going to give you another scenario here. Again, I said in the big hospitals in this area, but one day I was surrounded, I was putting in the room and surrounded with the doctors, and they brought, like, before I know it, 6 people, like 6 men enter in the room, and there were law enforcement. And those law enforcement communicating with the interpreter. They did not interpret, they did not explain the process to me, what interpreter was. What it threatened me was the interpreter wasn't in the room, imagine. The interpreter was behind the wall, I could not see. Not only that, that interpreter sounded like my trafficker. That interview lasted less than 2 minutes. So we all lost. Law enforcement did not get what they need, and I did not able to provide the information they need. I understand sometimes can be like because of funding, you are not able to have interpreter in front of the patient survivors. But still, you have to explain the process. So the person you are talking to, you are trying to interview, can know what is going on. I said it before, it is very important that the patient should answer the question they are being asked on their own. If the medical personnel notice that someone is insisting on answering the question or insisting on being in the room, they should ask the individual to step out, to allow them to speak with the patient directly. Once a medical personnel has been able to create a safe space for the victim to disclose, the first thing they should do is convey a message of hope. Let them know that you are there to help, that they have rights, and ask them what they need. In my case, retelling the story is very important. In my case, I visited again in the hospital, this time with psyche. And I remember I was in the emergency room from 5 p.m. to 3 a.m. before they found me a bed. It's not, what bothered me, not only that, like we are put in the room to wait in the emergency room so many hours, but what bothers survivors is having like nurses and doctors come in over and over, ask us our experience. You should find another way how to do that. You could brief, like for instance, you could brief one another to make it short and try to make it a little bit easier for us. Having medical personnel who are trauma-informed, create a safe environment and ask important questions can make the difference between safety and continued exploitation for victims of trafficking. I'm asking you today, please continue to engage in this work, to continue to do training on this topic. Survivors, we are more than our story. We are the center of the movement. We are the ones with the lived experience of the crime. We engage every day in important work to raise awareness and fight trafficking in our communities. You cannot work to end human trafficking without survivors, leaders. Next slide, please. And we cannot fight human trafficking without addressing racism. I experience every racism with the institution. In my case, I thank my social worker, Heidi. One time when I was discharged from the cycle, after staying in the hospital after 11 days, they had put up like, follow-up care for me. And they announced this therapy that I was seeing for a long time. But every time when I go to this therapy, my situation was getting worse because I was being judged. And I was trying to explain to my social worker, Heidi Alves, and it took time, it took her, after I was discharged, he went with me to understand what I was talking about. She was able to, to observe what was happening. Went there more than 3 times, and one day she was able to join me in the session. And after witness what was happening, she told me, no, we need to move on. She found me another therapy, and that therapy was at Howard University, unfortunately. I love Howard University, though. And this time again, because of insecurity, my social worker decided I should go with a fellow from Polaris Project and was waiting in the room. It was during my meeting with this therapy, I was judged from every abuse ever happened to me. And finally, you cannot address the issue in human trafficking without addressing effect of racism without the medical field. In my experience, I have had to face the biases medical staff have towards me, my lived experience, and their biases towards my race. I have to come to America not only to overcome human trafficking, but to experience racism for the first time because of the way I talk, the way the color of my skin look. But also to continue their biases and education. I have faced biases toward medical staff have toward my race lived experience and their biases towards a race Education is the answer to both of the problems. Continue to engage and learn about human trafficking, but also continue to engage and learn about racism and how it affects your field of work. You all are already on the right path in this work. You have invited me today. I work with, in 2019, by the way, I wrote an article on racism in the anti-trafficking movement. Additionally, in 2021, I worked with other 3 colleagues to create a survey on racism in the anti-trafficking movement. And the results from the survey was shocked how survivors are treated with health care. I hope you all take time to read through these resources to learn more about racism and health care. You can also, next study, you can also read this publication from HEAL Trafficking and the Human Trafficking Legal Center to assist medical personnel in recognize the red flags as well as risk factors. It is a miracle I was saved. I am here, standing strong in front of you to inform you how together we can make our society systems better. I hope my story is an example of how we should value another life. I hope through my life experiences, we can together prevent any more of cases of human trafficking. Let my brightness light up in other human lives, and nothing about us without us. Next slide, please. And I'll take a question at the end. There's information of my contract. In case I can't get it, all of your questions today, you can send me questions through my email. I'll be more than happy to answer your questions. Thank you.
Can you hear us here? Okay, Fainess, that was amazing. Thank you so much. I'm just gonna look to see, are there any questions in this room? I didn't see any in the chat. I have one question for you about the traffickers. I think, like trafficking survivors, we have stereotypes about who they are, what they look like. I put in the chat my thought that, you know, traffickers can look like any one of us, and that we have to be careful not to assume we know what a trafficker looks like, a person who's trafficked. Can you say something about that?
Oh, so can you repeat your question, please? I'm sorry, one more time.
Okay, sure, of course. Okay, I'm going up to the podium. Just a second. There we go. So my question for you is, we have stereotypes about who and what traffickers look like, who they are, and we make assumptions about that. Can you speak to the range of individuals who are trafficking?
Well, I'm glad you asked that question. Majority of time, that's why I'm here today as a labor of trafficking, also and many others circumstances. Most of the time, like the social media, it's the social media out there, the message they spread, like say, like for instance, sex trafficking, like they think like human trafficking, just sex trafficking, light-skinned girl, like a chain, like tattoo, but human trafficking is more than that. Human trafficking can happen to anybody, as I said, regardless of gender, LGBTQ, male, female, women's. And also traffickers can be anybody, can be also family members, somebody we know.
Well, thank you for that
Like,
response.
don't just like depend of what you see on social media. For instance, when you go on the social media, search human trafficking, you're gonna see the sensational. So, like a stolen people, if candy and those all that. It's more than that. So you have to educate yourself. Thank you.
Thank you. So now we're going to go into our breakout sessions. And for people who are live and aren't going to do it by Zoom, we're going to ask you to get into small groups. And hopefully, I don't know what kind of mix we have here, but to do our best to be in groups where folks are coming from different disciplines or different professions or programs. And for those of you who have been in breakout sessions before, you know we ask you to assign a scribe, someone who takes notes, so we can put them in the chat. And here's what we'd like you to do. We'd like you to introduce yourselves and your discipline, profession, program, and what you're aspiring to anyway, once you graduate. And then we want you to list the risk factors that or flags that Fainess did such a great job in telling us about and how they indicate risk for trafficking. And you might even note down some questions that you have about those red flags and indicators. And then we want you to discuss how or when you might encounter these signs and how you might take action. So those are a lot of questions. We may not be able to answer them all, but we really would love you to have a great discussion in your breakout sessions or small groups. Okay. taking input from folks in this room and in other real-time rooms. What else were some of the takeaways? There was a discussion about the difficulty of knowing what to do when you might see these red flags, and you really don't want to put anyone at risk. And there was an earlier question about, are we getting better at this? And I'm really curious about all of our health profession students, our medical students and our health profession students, whether you're learning about this in your classes. Is this in your curriculum? Deja, I'm looking right at you.
No, not really.
Yeah.
Like this, we were required to go to. So sort of, I guess, through this, but otherwise, no.
So maybe advocating for having this in curriculum. Fainess really would love us to do that, to at least have providers be aware of some of the signs. And so I have breakout room 5, signs of sexual abuse, denture decay, and genital trauma. I think oral health is a place of identification that we don't think about that often. But Fainess really suggested, when someone said to you, you're too young for your teeth to be falling out, you know, what's going on with you? History of unpaid bills, confusion. And then I have a comment here about cultural perspectives that, you know, some developing cultures feel that victims of trafficking and abuse should be grateful for coming to the US, that there's a bias about that, a cultural bias about that. Another sign might be there isn't a clear home address or a valid home address. So many comments here. I really encourage you to look in the chat and to learn more from each other. I think for me, one of the takeaways is please be curious. If something strikes you as a red flag, if something strikes you as not being right, ask about it. And if someone is in the room and you don't want them to be there, that they seem to be taking over the session, ask them to leave. It's okay to do that. Okay, does anyone else, Michelle, anyone else we spoke about the role of provider can play in allowing for a safe space to speak. So my question would be, how do you create a safe enough space? And I think Hanni is going to be talking about that in just a minute or two. How do you create a trauma-informed, safe enough space for people to be willing to take a chance? So it's my pleasure to turn this over to Hanni.
Thank you so much. And a little preview that answers a lot of your questions is the pair tool. And we'll get to that at the end of my little bit here. But I just first wanted to express my gratitude and appreciation and joy. It's beautiful to see the breadth of professionals that are here today with us. And I really do see the movement that will be sparked today. And I'm so excited to be witness to that and a part of it. And just thank you. Thank you for having us. We, to level set, you know, we've been talking about trafficking for the last little while here, but what is trafficking? I encourage you to think about what your own definition of that might be. Feel free to share that in the chat or just reflect kind of quietly to yourself. But at the core of it, we're talking about someone profiting from the exploited labor of another individual. And really the kind of guiding star of definitions that we use here in the United States is based on the Trafficking Victims Protection Act. And it has these 3 core components as we think about a crime that may be perpetrated against potentially one of our patients. And so this is not a passive crime. The trafficker has to do something. And it might be anything along that victim's journey, including the early on recruitment phase. And there has to be force, fraud, or coercion that's keeping that individual in that situation. And many times, as we heard from Fainess, these are interrelated and happening all at the same time. Coercion, we see the power of psychological coercion, and that somebody might not even have a mark on their body, but that psychological coercion can be so powerful. We see debt bondage as a form of fraud. There was recently a case in New England where someone smuggling debt ended up being the debt bondage that kept them working in a restaurant situation, and their families were being threatened. And then, of course, we think about sexual and physical violence that keep folks in situations. And you've heard us use the term sex trafficking and labor trafficking. So those are the two kind of main common ways that we talk about two types of trafficking in the United States. And very, very importantly, there is an exception to what we described as the need for force, fraud, or for coercion for someone to be considered trafficking when we talk about those under the age of 18 who are engaged in commercial sex. So anyone under the age of 18 engaged in commercial sex, regardless of whether or not there's force, fraud, or coercion at play, is considered to be trafficked by US law. And then the reason that we're here today is because of research like this that has shown us that we know the majority of those who experience trafficking in the United States have some touch point with healthcare at some point while they're being trafficked, which represents such a huge opportunity and responsibility for us all. So in this next little bit, I'm going to talk about my own journey of unlearning. And, you know, I reflected a lot on what I would share today with all of you. Each of these topics, like how to work with interpreters and each of these things that we've mentioned could be their own sort of day-long session. But what you rarely hear in the healthcare and trafficking space is really this unlearning piece, this acknowledgement that none of us is a blank slate when it comes to trafficking, and that we, just like me and my own journey, all need to be unlearning and then learning anew. And so I'm going to share my own journey with all of you today. So thanks. So the first piece to unlearning for me has been that reflection of my own lived experience, my own personal history, as well as the history of my family. And to recognize that I grew up as a pastor's kid. I grew up with not a lot, and that I'm a white cisgender female. And so I actually have a lot of privilege in society. And then fast forward, now I'm this Harvard emergency medicine physician. And that carries not only a lot of privilege, but it also sort of trains my brain to think in a certain way. And some of those things are really helpful when it comes to trafficking, and some of them actually have to be unlearned when it comes to approaching any of our patients who are experiencing exploitation. So first, I just wanted you to take a moment and think in your mind's eye, create that mental picture. You can close your eyes, do whatever works for you. Picture someone who's experienced trafficking, who immediately comes to mind. It may be one or two people, it may be one individual. And of course, we just heard from Fainess, but just allow your mind to think about that question. When you hear the word human trafficking, when you think about someone who's experienced trafficking, what initially comes to mind for you? And if it works for you, you could write it down or just note it in your mind's eye, but think about that individual's ethnicity, race, sexual orientation, gender, type of trafficking, like just really try to get as detailed of an image in your head. Maybe think about the type of exploitation that they've experienced. Maybe think about the way that you're interacting with them and the way that they're interacting with you. So as you're doing that, and as you did that, each and every one of you will have a different picture in your mind's eye. But what I would guess is if you're like me, when I first came to this topic, I did not imagine a male who was experiencing labor trafficking in construction industry. I did not imagine a transgender person who was Indigenous engaged in sex trafficking, in a sex trafficking situation. And I also, when I first started working on issues of violence, in the ways that I had been trained, I really thought that victims of violence acted in a certain way. And that the more that I learn about the way that trauma works in the brain is that it is biological rewiring that ends up with an individual being in fight, flight, or freeze, or fawning. And that is beneficial. That's how that person is surviving. And yet, whenever I had patients that were acting in these ways, I was one of those people that wasn't curious initially. I really had labeled that as bad behavior or what have you. And as I've learned and been on this journey, informed by those who've experienced trafficking, informed by other forms of violence, I've had to unlearn and to recognize how trauma changes the brain, and to be curious, to ask those questions with my patient rather than automatically labeling in a negative way. So this first bit of unlearning is really that we all as humans have bias, period. And then as it relates to trafficking, about who experiences trafficking and how trauma manifests. And there are lots of pieces to how that bias is shaped. But really the first step is that awareness and doing that internal reflection work. Fainess talked about the role of racism, not only in relation to her vulnerability to trafficking, but then also as it relates to the resources that she is able to access. And I want to mention here, part of my own unlearning was really getting to the root and understanding, and I'm constantly learning in this practice, of the difference between equity and equality, to recognize that we are not all starting on a level playing field. And if the goal is a happy, healthy, joyful life, that equal approaches and one-size-fits-all approaches do not work. And so I asked the question, what does an equitable approach to healthcare response to trafficking look like? And I'm going to be asking a lot of questions here and leaving them with you. I encourage you throughout this, we're just scratching the surface to really consider these questions. And some of them we'll be able to get to, and some of them we may not to in our discussion time. As I think about some of the inequities in the anti-trafficking response, and that directly relates to the healthcare response to trafficking, I look back at the history of the anti-trafficking response in the United States. And it shows me that it's no accident that there's less understanding of labor trafficking, and there's less resources that are being devoted to labor trafficking. And that's because the history, like many things in the United States, has underpinnings of xenophobia and underpinnings of racism. And so as we think back to that tree of equity and creating a world of equity, what does that mean in relation to labor trafficking? What does that mean as it relates to our role as professionals in responding to trafficking and being part of that change? So in reflecting for myself, I know that if I'm not actively mitigating inequities, I'm actually contributing to them. And one strategy for overcoming inequities is by focusing on the forgotten. For example, labor trafficking. Now, for those of you keeping track, I didn't get out of order here. This is unlearning 3. So the first rule of medicine, and as a doctor, I've taken the Hippocratic Oath, is this core Hippocratic Oath of do no harm. And on this journey for myself, one one thing that has become very apparent is that in looking at the history of the United States, there have been things that resulted in unintended consequences that could have come from a place of good intent. For example, trying to decrease, drug use in the United States actually led to mass incarceration of Black people. So digging down into the healthcare setting, I want us to think through two different examples of how good intent might actually result in harm. And so the first one is right here on the slide, thinking about a policy to call 911 for trafficking victims. So think to yourself, like, why could that be potentially harmful? So the reason, I'll first also kind of get a little meta here. The reason I have this on the slide is I can't tell you how many folks, it's like a gut instinct that as they're learning about trafficking, there's this desire to do something and do something immediately. And many of us have not had negative experiences with law enforcement. And so I can't tell you from across the country, it doesn't matter where you are. I've heard this desire to call 911 right away when there's no protocol in place. And the reason that could do harm is that many victims of trafficking have been forced to commit crimes as part of their exploitation. And so by calling law enforcement, particularly calling the wrong law enforcement, you may end up harming that person by getting them arrested or deported. And moreover, as we've talked about, like having that victim-centered approach, that trauma-informed approach, it may not be what the person's asking you for, right? And how do we center that person in front of us in everything that we're doing, regardless of how we feel? Here's another example that I want you to think about. This one's a little bit more nuanced, I would say. And I got this picture off of my Facebook feed one day, a few months back. And I thought that there was a lot of really good reflection that could be had here. So I'm just going to read this sign. This was a sign that people were putting in hospital and clinic bathrooms. Please put only your initials on your specimen and place it on the back of the toilet. Your nurse will collect your specimen. Thank you. And there's two Sharpies here. One's black and one's red. Please write your initials with the red marker on the specimen cup if you are experiencing intimate partner violence, domestic violence, or anything else you wish to discuss in confidence with your provider. We will ask anyone accompanying you today to leave the room before discussing your concerns. So I want you to think, we're in that vein of like, what's bad about it? There's certainly some good things here. It's a private setting. We've talked about how important private setting is, but to flip it on its head, what could go wrong, and who, moreover, like who's left behind, and therefore the harm of not really reaching the most vulnerable folks. I'm going to try to look at the chat. If they can't read, yes, thank you. This assumes that everyone can read English. Yes. Yes, those are the top two. And so literally, we've talked about vulnerability to trafficking. Those two groups are at high risk of trafficking and other forms of violence. So the very folks who most need this information and need to be helped are excluded by this. And there is a potential for some other forms of harm, but thank you for participating in that exercise. Just another example, I know I'm sort of hitting you over the head with this, but another example of how good intent may not lead to good results. This is going to date me, but there was this like anti-drug thing among youth called DARE. And it actually, the goal was to decrease drug use. There actually was an increase in drug use as a result of the way in which that well-intended program was implemented. Part of not doing harm is also not reinventing the wheel, but to redesign it using an intersectional approach. So what I mean by that is that we've been learning. So while trafficking is relatively new on healthcare's radar, we've been learning from survivors of other forms of violence for years. There's a rich evidence base of what creates harm, what doesn't. And we absolutely need to to do better and to learn from that and not start from scratch when it comes to trafficking. And here's a cartoon with unintended consequences where people misread the sign. If you're not convinced that there could be unintended consequences by now. Another solution, so looking at intersectional approaches, one piece that we know and we've learned and is best practice from other forms of violence is that in creating these solutions, who do we have at the table? Who's helping us to design those solutions? Fainess closed by saying nothing without us, nothing for us, but without us, right? Nothing for us without us. And so, you know, even as we take that bathroom sign, if you had folks that had lived experience of these forms of violence, like advise you to help create an intervention, in the folks that we talked about that may not represent the sort of literate groups or folks that don't speak English as a first language, that would have been caught right off the bat, right? And so really thinking broadly, how do we have a diversity of perspectives that breathe into and help us to create what response looks like? And do we have migrant workers? Do we have people engaged in commercial sex work? Because they're all going to be affected by the policies that we create. So unlearning 3 for me was don't assume good intent equals good impact. Good intent can really lead to harm. And so how do we avoid that? We involve affected people. We look at evidence from other forms of violence. So to summarize here, for my own unlearning, which I really hope will inspire your unlearning, is to know your biases and then work to mitigate them, and have that be a continual practice. Overcome inequities by focusing on the forgotten, for example, labor trafficking, and that's just one example. Good intent can lead to harm, so we must involve affected populations and really do our homework. So I previewed here that the approach that needs to be taken is the pair. It's called the pair tool. So I'm just going to click on this slide here. And again, these are all things that we could spend an entire day talking about. The pair tool was created by looking at interpersonal violence responses and looking at that rich literature and learning from survivors that the goal is not to rescue. The goal is not to do some like checklist. Do you feel safe in your relationships? And ask these, esoteric screening questions. But the goal is to plant that seed to build hope and to let someone feel safe and give them the resources, as Fainess said, to let them know what their rights are, and then respect and respond based on what you learn from that conversation. And so I'm just going to briefly talk through an example here. In my own emergency department, we often have patients who've experienced substance use, who are engaged in situations of sex trafficking. And the way that I'll open a conversation with this very high risk population is, thank you in the chat, respect and respond, I create a private moment. And sometimes it is, as in my breakout, we talked about getting creative, using the resources you have to create that private moment with your patient to have this conversation, to educate, ask, respect, and respond. So I'll say, as your doctor, I care about your health, and your health is related to your work and your relationships. And a number of my patients who use drugs end up meeting the wrong drug dealer who controls all of their life, threatens them, and they feel like they can't leave that situation. Has that ever happened to anybody you know or to you? The reason I'm asking is we have resources to help people in that situation. So you can see that that's very different from, do you feel safe in your going down a checklist? And it opens that door. And I'll tell you, I've gotten the full spectrum of responses from that. But what I know that I've done is centered that person in that conversation and empowered them with information that's then in their hands. So rather than me controlling and me taking the power, I'm giving it to them. So I'm getting messages, so I'm mindful of time. Just a little bit about HEAL. I encourage you to join our network. We have lots of open access resources that we're sharing across our network. And we have over 4,000 folks, including those with lived experience. But just to pause for a second, like, we are creating history right now. You are creating history in everything that you do, and you have choices in that. And I encourage you to go on your own journey of unlearning as it relates to trafficking and other forms of violence, and really make a difference with this responsibility that's also an opportunity. So I'm really excited to see what comes out of this time. And thank you so much for the opportunity, Chris or Shelley.
And can you put our contact at the bottom, like email, so for Dr. Hanni and myself, in case we can't get to all the questions? Please, thank you.
So does anyone have questions? I know I have some, but I would love them to come from you. Put them on the cards or put them in the chat. So there are a lot of information in the chat and questions in the chat about law enforcement and how law enforcement is trained, how law enforcement and healthcare should be working together and from a trauma-informed perspective. So I'm curious about your thoughts about working with law enforcement. Have you seen it work well? Have you seen law enforcement officers and leadership change?
Is this a question? Can I answer that? For me, I have like bad experience. Well, they're good, like law enforcement. I had treated well law enforcement, but like then some of law enforcement, they had threatened me. I'm gonna give you one of the scenario. I was having breakout one time, and the social work, I mean, it was like social work, like called 911, and the law enforcement showed up, 3 law enforcement showed up, and it was all happening in the daylight in the middle street, busy street highway. And they patted me, they pat the way they did it, like it's more than the one they pat you at the airport, okay? They patted me that I was a criminal. Not only that, they handcuffed me. And I was screaming, get out of this of me. I'm not a criminal like that. So not only that, imagine they put me in front of police car. I wanted to jump out from that car, and we still have 2 police cars following us behind. So that was threatening for me. They should find a way to do that.
Well, I think one of our students, Christabel, and I don't know if she's in this room or somewhere else, mentioned that, you know, often certain communities don't feel safe at all around law enforcement and had negative experiences, like you're saying, with law enforcement. So it seems like a particularly important group to raise awareness with.
As well, some survivors had reached to go, go to the police station trying to get help, but it turned away back to their traffickers. So there's a situation like that. So there's mixed response when it comes to law enforcement. Yeah.
Thank you, Fainess. Hanni, do you want to make a comment on that?
Yeah, just a couple of things. One is by emphasizing like that law enforcement isn't the solution. I also know that like I sort of centered law enforcement out there. What I want to say is that as you're taking care of that person in front of you who may have experienced multiple forms of exploitation, maybe trafficking, to really center that person and what they're saying they need, first and foremost. And as you build response protocols, and we have a free toolkit you can download on our website, because you need to have that plan in place. Recognize that connecting with migrant health resources, recognizing that connecting with housing resources, like the unmet social determinants of health needs, are usually the ones that folks who are experiencing trafficking are asking for. In the minority of cases, at least from my experience, it's that law enforcement involvement, and it depends on what their situation is. And so I didn't mean to disproportionately talk about law enforcement in that way. And then it just, the history of the anti-trafficking space and law enforcement involvement really has, in a lot of times, they're just like not as trained on labor trafficking because many times they come out of vice units, et cetera. And so there's a lot of learning that needs to happen. But I also just want to center those other needs that those who've experienced trafficking are definitely asking for, and making sure that you have those, as many of those seamless connections in place and those protocols in place for the moment when that identification occurs.
So I think you're really reinforcing the idea of the intersectionality of this issue, that it can't be one or the other. It has to be the community, institutions, education, schools are places where trafficking has happened, and adolescents are being trafficked and schools are not identifying that. So I think it's the intersection of all of that which feels daunting. I think, Fainess, were you going to add something?
Yeah, I was just trying to add, in some cases, like law enforcement, when they are called, they end up like sexually assaulted survivors instead of helping them. And also, like me, law enforcement, they threaten me sometime, because when I see law enforcement, I have a background where I was sexually assaulted at gunpoint on my head. So me having law enforcement imagine next to me, I know that they have gun and they put me in the police car. So it triggered me. It triggered my past experience.
Thank you. There's one more question I think we have time for from Linda Morrison. She asked, could one of you speak to the tricky issue of BIPOC clients and the fear some clinicians have about being perceived as racist when they are actually noticing red flags?
Fainess, do you want to weigh in?
Can you repeat the question, please?
Sure. And this is speaking to the peer model actually as being a wonderful tool, but Linda is concerned that sometimes it may be construed as racist if you speak to trafficking or begin to question whether you're identifying red flags in a clinical setting if someone is BIPOC.
Well, I don't think I really understand the question very much, but I know you do, it's my part. But in a matter of that, you mean in a matter of interacting with the patient who's BIPOC population. So in a healthcare field, when I shared that you have to, for instance, create trauma-informed materials or education at the same hand, for me, it's looking in your team, look around and see if there is you have representation, because representation matters too. So you have to look for a representation. You have to consider culture dynamic and the representation approach.
Right.
So yeah, Fainess. So basically, engaging with folks with lived experience of being BIPOC in designing interventions with health professionals so that they're, able to navigate these situations. And I would just add to that, what's beautiful about the pair approach is you're not labeling, right? You're literally providing information and, creating that open door. Which I think is a really, I know it's a powerful approach based on what we've seen and from the literature as well as my own experience. And it switches the power dynamic, which I think core to a lot of that dissonance that may be described is this, health professionals inherently, I'm in power, right? And how do we give that power back to our patients? And the pair tool is one of those tools.
Great, thank you. Well, everyone has a copy of it, or there is a link to it in our chat and in our materials. So for those of you who don't have it, take a look at it. And do we have time for one more question? Yep. Okay. Well, my question is a broad question, which is, one of you said, and I think both of you actually said, that education is the key to changing the way we think and where we promote change in the areas of red flags and trauma-informed care. What kinds of things would you like to see in curriculum, in service learning, in other avenues of higher education and training for the health professions and other person-centered professions? You can dream.
I would like, I will answer this, then Dr. Hanni will jump in. I would love to see a lot of education in labor trafficking, because labor trafficking is excluded and labor trafficking survivors as voices are silenced because of that.
So paying more attention, or at least equal attention, to labor trafficking as well as sex trafficking, because sex trafficking is labor trafficking in a sense. So putting that in the curriculum. Hanni?
I would just add that adding, like, within whatever education, that there is that component of acknowledging that none of us are blank slates, that we all come with predetermined biases that play into how we interact with everyone in the world. And so having that, like, unlearning of biases as part of what that training looks like. I really am a fan of using simulation, of trying these structured conversations on for size, just like, that's how I've learned how to have end of life conversations with my patients, is by trying it out in a safe space with other colleagues using a structured tool. And I think we should be doing the same thing when it comes to forms of violence, including trafficking. And I +1, I absolutely underline what Fainess says, that, like, what if it was a world where, like, we're disproportionately talking about labor trafficking? Of course, we're going to talk about sex trafficking, but that as really, like, having that be the center, just as we've done today, right? Like, saying the word labor before the word sex, those kinds of things, very, very powerful tools to help with some of that de-biasing.
Yeah, it's simple. Just to stop dividing us, thinking like one type of trafficking is worse than the other. Because at the end of the day, last time I checked, when it comes to PTSD, there's no color. Like, this one has like yellow, whatever. We all, PTSD is that just the same way that we are sex trafficking, child exploitation, labor trafficking. So please don't divide us when you are trying to end this issue. It's the same damn thing, and you are trying to end the same issue. It's not a competition, period.
That was incredibly powerful. Thank you for that. I'm looking at my audience here in Bedford, and anybody have any cards at the end of the table that they'd like to ask questions? Because there's no more in the chat. Okay, so, well, thank you. Let's give a round of virtual applause or real applause.
And if we didn't get it to your question, you can again send your question to our email. My email is finessl@htlegalcenter.org.
And we would love to have you back on campus someday. That would be amazing. So thank you so much again. And I guess I'm closing out this session by saying thank you, everybody, for being here. I will say we had a groundbreaking number of people attend this. We had well over 300 people attending today, and your information is so powerful. I just want to remind folks that we've got a really good one coming up next week too. And Hanni and Fainess, you're welcome to attend it. It's on scientific literacy and looking at its impact on COVID vaccines and other forms of vaccine hesitancy and care. We're going to have an expert panel, both from folks inside of UNI and outside of UNI. And just go to our website and you will find a way to get to us. So thank you so much for being here. We're very excited and we feel like we've learned an enormous amount from you, and we appreciate your time. Thank you so much.
Thank you.
Thank you for having us.